Managing CRT-induced adverse events in unresectable Stage 3 NSCLC. The views and opinions expressed in this video are those of the individual oncology specialists and do not represent the views or opinions of AstraZeneca. This video contains anecdotal information gathered from a discussion with oncology specialists based on their opinions and experiences. Recommendations are general and may vary with patients. At the time of this filming, the healthcare professionals featured were in the roles and at the institutions indicated. Today, we will discuss how to manage toxicities as a multidisciplinary team, with a focus on the importance of early and frequent communication across the team, as well as the roles and responsibilities of everyone involved. We will also cover how proactive management of adverse events could help avoid treatment breaks.
Hello, I'm Janakiraman Subramanian. I'm a medical oncologist. Welcome to our video series on the changing landscape of unresectable Stage 3 non-small cell lung cancer. In this video, we'll be talking about optimizing the use of concurrent chemotherapy in unresectable Stage 3 non-small cell lung cancer. To help with that discussion, I'm joined by two thoracic oncology experts.
I'm Stephen Shun. I'm a radiation oncologist.
Hi, I'm Megan Roy. I'm an oncology nurse navigator.
The first topic is the importance of early and frequent communication.
Stephen, in your opinion, how important is the collaboration within the multidisciplinary team so that we are managing these patients effectively so that they complete their course of chemotherapy and radiation?
Collaboration with the full multidisciplinary team is of, in my opinion, utmost importance. The multidisciplinary team can be involved at times with input from the interventional pulmonologists, the nurse navigator, with day-to-day management of patients as they undergo treatment. For me, it's mostly a partnership with the medical oncologist and myself to coordinate care during chemoradiation about what they're going through regarding adverse events. With chemoradiation, we want to make sure they get through the full treatment course without treatment breaks, and that requires frequent communication about how the patient's doing. Because the patient comes in more frequently for radiation than for, let's say, weekly chemotherapy, we oftentimes can observe changes that might be happening more quickly than the medical oncologist. If there's an adverse event like esophagitis or fatigue or whatever adverse effect there is, we're the first line of defense, but we immediately let medical oncology know, so they're also on the lookout as to whether they need to do more workup in relation to side effects of chemotherapy.
So Megan, how do you see yourself in making sure that the collaborative environment continues to work so that the patient is managed appropriately throughout their course of chemotherapy and radiation treatment?
My role is to bridge those communication gaps between medical oncology and radiation oncology and the rest of the team that's involved. I reinforce the education of what adverse events they should look out for, so this way they can report it as soon as they start feeling it. Because again, if they say to me like, gosh, all of a sudden I was short of breath walking out to my car, it's a red flag to let somebody know, to maybe they need some imaging to make sure they don't have pneumonitis or something. And during tumor boards, again, these multidisciplinary tumor boards are so important. So we got to make sure we have all the relevant information so the specialists can make their decisions. I'll report any issues the patient's having to get them through treatment. For example, if the plans for them to come to the city every day, but they live right near one of our satellites, I might mention like, hey, they don't have a drive. Is there any reason why they can't go out to a facility and help with those logistics? And also keeping that patient voice up and present if a patient, does have the final say of what treatment they want. So making sure that they are part of that treatment decision process.
How do you keep them motivated so that they can continue through with their treatment?
I really do think that morale is such an important part of what we do, whether it's morale on a boat or morale during chemoradiation. But I always like to frame this in the broader perspective that today with chemoradiation and consolidative therapy, this truly is curative treatment.
Our next topic is roles and responsibilities across the team.
So, what do you think is the role for the multidisciplinary team in helping you manage these adverse events for these patients?
I had a recent case of a patient. It was in the middle of chemoradiation. People didn't know what was going on because of worsening respiratory status. I was pretty clear that this is probably not from radiation because pneumonitis doesn't happen during radiation. This patient also, because I talked with a pulmonologist, they thought that their COPD wasn't bad enough to be causing their hypoxia, that they would be really surprised looking at the pulmonary function tests if the COPD was doing this. And sure enough, viral panel, it was influenza. So the multidisciplinary team should always be looked to especially when things might not be going as planned.
Agreed. I've personally found it helpful, just like you said, to talk to my partners in the multidisciplinary team. Sometimes it may be looking at an imaging study with my thoracic radiologist to help me understand what's going on. Like you said, is it pneumonitis or is it, something else that's happening for these patients? Like could be an infection. And as you said, the timing of pneumonitis, knowing that is key because radiation pneumonitis takes at least several weeks after radiation to develop.
The final topic is helping patients avoid treatment breaks through proactive management of AEs.
Stephen, how do you try to avoid interruptions to radiation treatments or dose reductions? The delays or dose reductions could be significantly detrimental for their ultimate outcomes, isn't it?
That's absolutely correct. And we know from many decades of research at this point that interruptions or dose reductions lead to less of an ability to control not just lung cancers, but all sorts of lung cancers. I break it down to patients. We're trying to kill this cancer, and we keep kicking it, and you want to keep kicking it while it's down. If you have a break in radiation and allow that cancer to stand back up, you're risking not being able to kill that cancer. That, in a nutshell, that's how I conceptualize it. Kick it while it's down and don't let it get back up. And this is also why I think involving social work is incredibly important. While we certainly have a lot of medical issues, medical logistics to address, there are also incredible social logistic issues. We can address all of the medical logistic issues as much as we want, but if the patient doesn't have a car or transportation, it almost becomes a moot point. Managing proactively is critical to maintaining that morale that we spoke about earlier, having the patients, have a good outlook, and that helps avoid breaks in radiation, which we know is detrimental to local control and survival. I actually tend to call in the supportive care team early in treatment, especially for a patient who's running into trouble.
Megan, how do you kind of help to manage these adverse events for these patients?
I don't manage these toxicities directly, but I help bridge the gap to the teams that need to be managing them. So if a radiation nurse notices that this patient's looking dehydrated and especially fatigued, I might reach out to the medical oncology team and say, hey, do you think IV fluids might benefit this patient, and help connect the dots both ways.
So what tips do you have for the different adverse effects that the patients are dealing with when they're going through chemotherapy and radiation treatments?
We encourage the patients to stay hydrated by drinking their 8 glasses of water a day. We're going to be monitoring their blood pressure and checking their labs, checking their skin turgor to make sure that they're not dehydrated and they don't need IV fluids. For weight loss, the labs are also going to be checking their albumin. We're going to be weighing them to make sure that their weight's staying stable. And again, the nutritionist is a crucial part of the team, and they can recommend some nutritional supplements, liquid, if needed, and help them set their calorie goals and protein goals for their intake and decide whether it's time to start thinking about a PEG tube.
The most common side effect that we see during radiation that gives us the most problems is the esophagitis. It causes pain, and because of that pain, patients don't eat. It causes weight loss. So I usually start patients on an antacid, because if there is any acid reflux component of their esophagitis, we want to neutralize that stomach acid. Other medications that I prescribe, in addition to pain medicines, I always send in a prescription for a stool softener because I know invariably that narcotics are going to cause constipation.
The whole idea, like you said, is to be proactive and have a combined multidisciplinary approach so that we can prevent and control these adverse events as much as possible so they don't become too severe as soon as treatment's either completed or stops treatment in the middle. We don't want that either. So we want our patients to be as healthy as possible after treatment so that they can recover, and also because treatment's not over yet, there is consolidation part of the treatment. They should be in a good shape to go ahead and get those treatments.
Yeah, and I'll typically talk to medical oncology after radiation is over to discuss when we should schedule the post-chemoradiation scan to check for disease status, particularly checking if there's progression, because that determines what the next steps of consolidative treatment are going to be. We'll typically schedule the scan between 2 and 6 weeks after completing chemoradiation, although that can vary depending on the medical oncologist and the situation of the patient.
And we need to keep in mind sometimes when we do these scans early on, we may not necessarily see a great response to treatment. We may actually see some tumor changes that might suggest that there is progression. But we need to keep in mind that not every slight change in tumor size is progression of disease, particularly if you look at the RECIST criteria. The maximal diameters of these tumors should be increased by more than 20%, that really to say that there's true progression, or they should have some new lesion that's clearly cancer to call it progression.
In summary, manage adverse events along with the multidisciplinary team to help patients complete therapy. It's important to keep patients motivated, and proactive management of adverse events may help patients avoid treatment breaks.
This concludes the videos in our series on the changing landscape of unresectable stage 3 non-small cell lung cancer. Thanks for watching.